Hello, my name is Brian Casey, editor-in-chief of AmpMini.com, and we're here at the 2019 edition of the RSNA meeting in Chicago. We have with us right now Dr. Rebecca Smith-Bindman of the University of California in San Francisco. Dr. Smith-Bindman is an expert on radiation dose, particularly in CT. Dr. Smith-Bindman, thanks for being with us.
Thank you so much for having me.
Yeah. So radiation dose has been a really important topic in radiology, particularly in CT for a number of years. You've done a number of important papers in that area. Um, can you talk a little bit about what the issue is and if we're making progress?
Of course, I think there's growing awareness that the radiation doses are higher than needed and highly variable, but it hasn't been totally clear how we get to this variation, how we reduce it. What's causing the variation. And so I think in general there's much greater awareness, but I think the variation still persists. And that's really an opportunity for most radiologists to have their doses come down.
Yeah, because if you walk around the exhibit floor at McCormick Place, every vendor of every CT scanner has got some kind of dose reduction tool or multiple dose reduction tools, and there's discussion of sub-millisievert imaging and that kind of thing. But I guess the issue is whether those tools are being used.
I think that hits the nail on the head. So there are many tools that radiologists and medical physicists can use to lower doses, but it's not clear that those tools are used correctly. And as a result, we still have a lot of variation.
Yeah.
And so I think one of the things we're hoping to provide in the abstract we're presenting at this meeting are concrete doses that can be used as targets, diagnostic reference levels for a range of clinical indications.
Okay. So can you talk a little bit about the paper and how it was set up and what are some of the things that you found?
Absolutely. So the European College of Radiology has identified 10 common indications for CT that are both by anatomic area and clinical indication, that they believe it's important to have specific diagnostic reference levels. And so within the chest, as an example, there are very different dosing needs for a lung cancer screening exam or a lung nodule follow-up than there are for a diagnostic scan to look for pulmonary embolism. And so using those 10 categories that the EU have created, the name of those categories are Euclid, and do a very nice job of separating the clinical indications. We've looked at data from the UCSF's International CT Registry. We pulled data on 2.7 million scans, and we created diagnostic reference levels for each of these categories.
And so the diagnostic reference levels, those are levels at which the optimal scan would be performed.
Not exactly. The diagnostic reference levels by tradition are usually set at the 75th percentile. So in Europe, they're used as levels that should not be exceeded unless there's good clinical reason for doing so in an average size patient. So these are not, the diagnostic reference levels that I mentioned are not the best doses. We've also presented target levels. Those are sort of optimum doses, and those are set at the 50th percentile distribution. And there's still enormous variation across the 150 plus hospitals in our registry for each clinical indication, but these are looking at target levels and benchmark levels, pooling the data from all of them, and are a good place to start when you're thinking about what the dose should be, for example, for routine head CT to look for hemorrhage.
So this is sort of the first step in setting these benchmarks that facilities can try to achieve.
That's right. In Europe, people treat the benchmarks in different ways. So some countries will use benchmarks as a motivator for lowering the doses below that. Others will use them as the actual doses. But they're the first step in setting a target to reaching lower doses. If you know what dose you shouldn't exceed, then it helps you to continually lower the doses. So in Europe, they are asking countries to create these benchmarks, and we, as a way to sort of provide additional information to the consideration of dose, have pooled data from our registry to show sort of what these doses are.
Now, how would you like to see U.S. facilities using this information?
Well, I think it's really important. The first step is facilities to look at their doses. And you can look at your doses with an anatomic area. What are your head doses compared to, let's say, the ACR benchmarks? Certainly a good way to start, but this provides a little bit more granular information. What are your doses within these clinical indications as the next step to say, okay, are we achieving doses that are truly LARA as low as reasonably allowable?
Okay, great. Do you think in general, do you think we're making progress on the issue of radiation dose?
As I started to say at the beginning, I think there's great dose awareness. But in terms of actual progress, I'm less convinced that we're doing um, lower doses now than we were doing several years ago.
Mm.
And I still think the main drivers of higher dose is using unnecessary multiple phase scans.
Mhm.
And I think that has not changed tremendously over the last couple of years. So I think awareness is a good thing. I think some facilities are in fact doing a really good job of lowering doses, but there are many facilities that are not doing that. And so I think there really is an opportunity to improve. I think certain groups of patients, such as children, are benefiting from lower doses, and that's demonstrative. The doses are going down over time. But in adults, the improvements have been smaller and more sporadic.
Well, hopefully with research like what you're presenting, we can continue to see some progress.
I think caring about dose is a really important first step that we've taken. I think the next step is to come up with concrete benchmarks that physicians can try to achieve, and also that they can be judged on the basis of, are you achieving these very achievable doses for all the indications for CT?
Dr. Smith-Bindman, thanks for being with us.
It's my pleasure. Thanks so much for having me.
Signing off for AmpMini.com, my name is Brian Casey.